Now, the reason why I agreed to come and perform here today is that I want to know what the whole subject looks like from your point of view. So I hope to be direct, questioned, lots of interventions from you, because that's what I really want to know, how the world looks from your point of view. How many of you have already been on the wards? So good, because then your personal witnesses to rationing, and I shall expect an input from you. Okay, now, first of all, I want to change the title, if not of the session, certainly what I'm going to say, which is, my theme is, rationing is inevitable, has been inevitable, and will always be inevitable. And there's nothing special, I think this is important, there's nothing special about the NHS. There are lots of ways the NHS may ration, different other healthcare systems, but all healthcare systems ration. And remember, again, the word rationing, the root of it is ratio, Latin for reason. So, although ration has become very much a sort of boom word, everybody thinks if you ration, it's a sign of failure. Actually, I think you can think of it another way, which rationing is a means, hopefully based on reason, of apportioning scarce resources. And resources for healthcare always have been and always will be scarce, not necessarily because governments are mean in the amount they spend. Think of the United States. Spends almost twice as much as the UK as a percentage of the national income, and yet it rations. It rations in different ways. It rations, for example, access. If you're not insured, you're not going to get as much health care as if you are insured, and so on. Now, very quickly, what are the different ways of rationing? Lots of different approaches. What have I offered? Come on, I'm going to sit here silent until I get some sort of response. And the only thing I would say is please speak up with age, or does not, one's hearing does not improve. Or I could put the question another way. While you're on the wards, have you seen anything which you would call or consider rationing?
Reduced workforce. Reduced workforce. Reduced the number of people working.
Reduced workforce.
Sorry?
Reduced workforce.
Yes. So reduced workforce. Okay. What else?
Organ transplantation.
Very good example. Yes. Or nothing to do with financial resources, but the number of organs is finite. Therefore, you've got to have criteria for allocating them, otherwise known as rationing. Have you seen any signs that, for example, drugs, particular drugs can or cannot be prescribed for financial reasons? Not yet. That'll come. Okay. So, all right. I think the workforce one, rationing, cutting back on staff, is a very good example, because usually when people think about rationing, they think about drugs in particular, of course. That always makes the headline, particularly cancer drugs, expensive cancer drugs. Why aren't they prescribed and so on? Because we can't afford it, perhaps. But there are lots of other resources in healthcare. What people forget, I think, is here soon you'll be dealing with patients. Now, patients like reassurance. Probably the most valuable thing a doctor can actually produce is to reassure a patient. But reassurance takes time. Now, isn't the first thing doctors ration is their own time? I went to see my GP this afternoon. He has 10-minute slots for each patient. I'm sure a lot of patients would love to have a sort of comforting chat with, but he has to ration his time. And no doubt you will have to ration your time. But, again, with the workforce, most of the time, are we rationing the quality of the care we're providing? In other words, it's not just drugs. It's not even operations. We're having to wait. And rationing by delay is one of the classic ways of rationing. You don't actually say no to a patient. You put the patient on a waiting list. Waiting lists aren't what they used to be as instruments of rationing, but they will probably come back. Now, right, is that a reasonable way of rationing? Probably, because one of the things that may happen is that patients may recover while they're on the waiting list anyway. So quite a sensible way of rationing, but politically intensely unpopular. So you can ration access, as I said earlier. America and some other countries are a good example. Healthcare isn't available to everybody. Not everybody is covered by insurance or a national scheme. Once you get in the system, you can be rationed by delay. When you be rationed by delay, you may then find that particular procedures are not available. Or, again, another example which you may have seen in practice, how many tests do you order? Do you order tests until you're 100%, 200% certain? Or do you in fact ration the number of tests you order? Post-operatively, how many nurses are on duty to make the patient comfortable? So all these ways we ration. So think of rationing as a sort of all-pervasive phenomenon which takes many different forms. Some highly visible, and those are the ones we talk about and which appear in the headlines. Others, the sort of marginal count in the workforce, for example, just a fewer nurses on the wards, rationing, but hopefully with much less visibility, much more difficult to spot that this actually is rationing. And going back to organ transplants, very good example, I think, because it's not just about money and resources. And it's a very good example of what sort of criteria, how do you decide who should get what? What are the sort of ways of, if this is surgery, some patients may need more time than others. Can you get it? How should you allocate things? Again, you'll be sitting there. What am I offered? What sort of criteria could you use when you're rationing? Come on, you can't be here just for the drinks afterwards. You've got to earn them.
You can give a disability weight to whatever their condition is, so you can try and have an objective sort of weight to the condition they have and the effect that has on their life, and put time according to that.
Now, can I just press you on that? Yes, you consider their condition. But what are you looking at? Are you looking at the most seriously ill patient, or are you looking for the patient with the best capacity to improve? You have two patients there, both desperate say, but now, you think, well, I will go for this one who's slightly less ill because, in fact, I have much better chances of recovery. Or do you go straight for, right, this is a life I must save if I possibly can, even if that life will end in a few hours. Capacity to benefit or seriousness of the condition. All right? I want to jerk you into life. Let's have a vote. Who would vote for the capacity to benefit? Right. Who would vote for the seriousness of the condition? Nobody. Okay. You're agreed. Good. What a pity, in fact. I wanted some discussion about that. Would you take into account, now that is particularly sort of organ transplants, the merits of the patient, the very particular characteristics of the patient? Will you ask her, is this a great musician, and I want to preserve him or her to give lots more concerts? Will you ask, this is the mother of 25 children. I must keep her alive to look after all those children. All right, again, let's have a vote. Would you take into account the personal characteristics of the patient? Yes. Who votes for yes? A few timid hands, I see. Who votes against? Rejected. So you're absolutely neutral about the characteristics of the patient.
The only characteristic I would take into account is whether they'd be likely to look after the organ after they've been given it. For example, if they're a heavy smoker or a drinker, that would be the only characteristic I would take into account.
Whether they would
Look after themselves after, for example.
whether they have the discipline, as it were.
Yes, for example, if they needed a transplant because of being a heavy drinker, if they were to carry on drinking after they've had the transplant and therefore put themselves back into the same position, that would be the characteristic.
Are they likely to follow the prescribed regime?
Yes.
Right. Is it the same or is it different from the characteristic of the patient?
Well, it's
Slightly different, isn't
personality
it?
characteristic, I would say.
Yeah. Would you take into account the causes of the trouble? Would you give preference, say, to a non-smoker as against a smoker when you're dealing with whatever it is, cancer and so on? Who would take the behavior of the patient into account? Anybody in favor? Against? It's a tie. You're a splitter on that. Now, other great thing is, should you have, I can't resist this one because I'm bringing you the latest news about rationing. Now, eligibility. Now, one of the things which has hit very hard is that in different parts of the country, private care trusts have imposed different conditions of eligibility for elective surgery. Consider what I've had, knee replacements. How do you decide who should get them and when? Now, what's increasingly happened is that PCTs have tried to introduce conditions of eligibility. In other words, people have had to fill in a form about their capacity to lead normal lives, to go upstairs or whatever, it's shopping, they're shopping or whatever. And then there's a scoring system, and if you score enough disabilities, So, a fortnight ago, interestingly, and this will affect your future, in fact, Sir Bruce Hill, who's the Chief Medical Officer, was giving evidence to the Public Accounts Committee. Now, probably most of you don't read the proceedings of the Public Accounts Committee, which looks at how money is spent in healthcare and elsewhere. Fascinating. Well, when you've got the time, which you never will have, I recommend reading their proceedings. Anyway, there was the Chief Medical Officer giving evidence, and the whole question of thresholds for eligibility came up. And he told the committee that I'm now relaying this as fresh news to you, that he in fact is working on getting NICE to devise national criteria so that the same criteria of eligibility will be applied throughout the country. But which brings me to my last point. Should you, in fact, when you're rationing, whether it's thresholds or whether it's your criteria for using particular drugs or not, is national uniformity important? Should it be the same throughout the country, or should these decisions be made according to local priorities? Say you've got two PCTs in future clinical commission groups. Now, he has got desperately underdeveloped, let's say, coronary care services. He has got brilliantly developed services. Now, both are considering whether they can afford the money for a particular drug, say. You know, his services are pretty well rounded, he's got no particular problems, so if there is any extra money available, he'll say, yes, of course we should. Now, he has got these desperately poor services which need money pouring into them. If, quite likely, he then says no to an expensive cancer drug and argues that the money spent on that would actually save more lives invested in his coronary care services, is he necessarily wrong? Well, I'm not sure what the answer to that is, but I think I've exceeded my 20 minutes and I leave it at that.